Hi, my name is Brigitte Ordóñez, and my topic is summary about immunotherapy in renal cell carcinoma and ribavirin for chronic hepatitis E virus infection in transplant recipient. The definition. In the definition of immunotherapy therapy in renal cell carcinoma is the third type of virologic cancer and has a poor prognosis with 30% of metastatic patients at diagnosis. The antiogenics and target immunotherapy led to treatment remodeling, emphasize the role of the tumor microenvironment. However, long-term response are rare with a high rate of resistance. New strategies are emerging to improve the efficacy and the emergence drugs and under evaluation in ongoing trials. Ribavirin for chronic hepatitis E virus infection in transplant recipient. Hepatitis E is a liver disease caused by infection with a virus known as HEV. The virus had at least 4 different types, genotype 1, 2, 3, and 4. Genotype 1 and 2 have been found only in humans. Genotype 3 and 4 circulate in several animals without causing any disease and occasionally infect humans. Application in medicine. Immunotherapy in renal cell carcinoma. The cytokine therapy involved EFN and interleukin-2 was the main treatment for renal cell carcinoma before the approval of target therapies. EFN has antiogenic effects promoting antigen presentation and dendritic cell maturation. The response rate of EFN was 15% with 3 or 7 month increase in overall survival. However, most response to EFN were not long-lasting and rare patients showed complete response. In addition, side effects such as flu-like symptoms and liver toxicity disable the long-term use of EFN. Interleukin-2 is a potent stimulator of T-cell proliferation and differentiation. In ribavirin for chronic hepatitis E virus infection in transplant recipient. The hepatitis E virus is transmitted mainly through the fecal-oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with the disease. The risk factors for hepatitis E are related to poor sanitation, allowing virus spread in the faces of infected people to reach drinking water supplies.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is 2 co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent to treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that is unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
So in moving forward, clearly, almost for the last decade, we've successfully, as Danny pointed out, extended progression-free survival, more than doubled, sometimes tripled overall survival. It's been an absolutely dramatic time for most kidney cancer patients. But having said that, where we have fallen short is that chronic therapy is required. Coming off therapy, disease progresses. Oral agents are still associated with significant, potentially life-changing side effects that change how people do. And we need to be looking for new approaches. And at this past ASCO and throughout our literature, it's very clear that we're revisiting, Jan, the role of immune-based therapy. For those of us that have given immune-based therapy for years, one recognizes that in our practices, if you ask the question, what's the most likely therapy a person received for a period of time and then had an unmaintained remission for years or decades, it's IL-2. And yes, IL-2 is difficult to give, and yes, IL-2 doesn't work in most people, but it does tell us something about biology. So the question, Jan, is are we revisiting the role of immune therapy in kidney cancer, and if so, how? And are we doing it the right way? Did we learn the right lessons from the first experience? Are we applying it in the second experience? And are the endpoints, the biomarkers that we're looking for in the patient populations, the right populations? That's a lot on your plate, but take a stab at it.
Thank you. Yes, immunotherapy is having a resurgence of interest, no question about it. Yesterday morning, we actually had a Society of Immunotherapy of Cancer symposium to talk about different approaches. And I will talk to your specific question, which is about the new understanding of taking the brake off the immune system with checkpoint inhibitors. But I wanted to just mention one point that was made, which is still underexplored and needs further evaluation, which is the combination of stereotactic radiation with immunotherapy to get an abscopal effect on tumor. And that has not been well explored in humans, but very well documented in animals. So that's another direction that immunotherapy is going.
So let's just be clear so the audience understands. So by an abscopal effect, you mean that giving local radiation therapy to a targeted tumor could alter the antigenic expression in a way that might allow for an immunologic reaction at sites that weren't radiated.
Correct. Correct.
And
Pros and cons. The immunotherapy in renal cell carcinoma. The interleukin-2 is a type of immunotherapy drug called a cytokine. It's a protein that helps your immune system fight cancer. A high dose of interleukin-2 can work well for a long time, but it can also cause serious side effects. Fluid in the lungs, trouble breathing, heart attack, bleeding in your intestine, high fever and chills, fast heartbeat, and other things to know about high-dose interleukin-2 immunotherapy. You will only get it if your doctor thinks you're healthy enough to handle the side effects. You take it an IV infusion and only at a hospital that has experience giving people high-dose interleukin-2. And the Ribavirin for chronic hepatitis E virus infection in transplant recipient, the pros and cons is that in rare cases, acute hepatitis A can be severe and result in fulminant hepatitis, acute liver failure. These patients are at risk of death. Fulminant hepatitis occurs more frequently when hepatitis E occurs during pregnancy. The first video.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
Hepatitis E, and they explained to me why there is a north-south gradient. Please.
I don't think I can do that, but thank you very much for the kind introduction. So I will be talking about the French experience with hepatitis E. And Professor Bureau told me I had 5 minutes, so I think I'll give you 5 main take-home messages that I think are very important for France for this year. So the first one is that acute HIV infection is very frequent in France. So it's a lot more frequent than acute hepatitis A infection, acute hepatitis B infection, or acute hepatitis C infection. Second message is that most of our cases are autochthonous, and HIV is a zoonosis, but there's also a risk of transfusion transmission of HIV. Third message is, I think, is the most important message for this year is that neurological symptoms are very frequent and are present in up to 20% of symptomatic cases. So this is new data. Fourth message is that HIV infection can be severe in cirrhotic patients. And the last message is that HIV infection can be chronic in immunosuppressed patients. So the first message, in France, we have mostly genotype 3 and some genotype 4. And you can, this is a map of the seroprevalence of HIV, and you can see that in Europe, the seroprevalence is around between 10 to 30%, compared to Asia, where it's close to 50% in some parts of Asia. But I think what's very important is that the seroprevalence within a country can be very different. For example, this is a map of France, and this is the latest data on HIV seroprevalence in blood donors. And you can see that within France, even though the seroprevalence is around 22%, there's a big difference. And there's a northeast gradient, but you can see that in the northeast, there's also a hotspot for hepatitis E. So this map shows that, for example, in southwest France, the seroprevalence is above 50%, and in one department, which is in the Pyrenees, the seroprevalence is over 70%. So there are some places in France where there's an extremely high seroprevalence in blood donors. And this table shows you the number of actual cases of acute hepatitis E that are diagnosed in France. So in 2002, there were only 18 cases diagnosed in France. In 2014, there were 1,825 cases. And in 2015, it's over 2,000 cases. But this is just the tip of the iceberg, obviously. So the message is that HIV infection in France is very frequent, and most cases are asymptomatic. Second part is about the transmission of HIV. So we know that in France, there's an animal reservoir. Hepatitis E is a zoonosis, so you can contract hepatitis E from eating animal meat that's not cooked enough or that's raw. And you can see that the species that can transmit hepatitis E are mostly pigs and wild boar. And the seroprevalence is up to 90% in some pig farms, and HEV can be found in up to 30% of pig farms in France. So this is a veterinary problem, I think. There's a risk of transmission from pig of HEV. And the highest risk is if you eat food that's not cooked, for example, dried food. And this is an example with French specialties, one from Southeast France, from Corsica, which is called the figatelli. It's a liver sausage, and the other one is a liver sausage from Toulouse. And if you take these meats, if you test for HEV, you will find HEV in around 50% of the different types of sausages. So if you go to a store and you buy this sausage, you can flip a coin and see if you have a risk of having HEV. But more importantly is the risk of transfusion, I think. And now it's a known risk. This is a recent study from over 50,000 blood donors, and you can see that 1 out of 2,200 donors was viremic for HEV. So that confirms the risk of transmission of HEV from transfusion. So there is a risk of foodborne virus transmission, but also there's a risk of transfusion or blood product transmission. And I think more importantly is this question is, if you have 1 out of 2,200 blood donors that is viremic over 1 year, then you can calculate the number of patients in France over 1 year that are actually viremic. So it's thousands and thousands of patients. Clinical characteristics of HEV infection in France is elder males, around 50, the mean age is around 50 years old.
Issue applied in Ecuador. Immunotherapy in renal cell carcinoma is the 14th most common cause of cancer in the general population, account for 2% and 3% of all new cancer cases detected per year worldwide. The estimated worldwide incidence of renal cell carcinoma is 15 cases per 100 population, but there is higher incidence in males, annual incidence of 20.7 per 100 population, compared with females' annual incidence of 10.5 per 100 population. Ribavirin for chronic hepatitis E virus infection in transplant recipient. Every year there are an estimated 20 million HEV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E.
So the next wave is these checkpoint inhibitors. There's at least 4 or 5 trials that I know of. I think only one with atezolizumab that's actually up and running. Others with nivolumab and durvalumab, and also, I mean, any drug you can imagine will be tested in that setting. It probably makes a lot more sense. It's going to be better tolerated for patients, I think. I think probably has the potential to extend overall survival, which would be ideal, which we haven't done to date, even with S-Track. And so we'll have those results in many years, but I think probably if we're sitting here in 5 to 10 years, we'll be talking about those drugs as standard of care.
And in conclusion, Ribavirin as monotherapy may be effective in treating chronic HEV infection. A 3-month course seems to be an appropriate duration for this therapy, so a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after initiation of therapy. Thank you.